fluid because each of the agencies offers something that the other one doesn't. So, in addition, there's going to be a structure change in the paramedic hierarchy because credentialing is so difficult to do in the sense of who's really qualified and who isn't. There's no way for me to know that. I can't tell sitting here with somebody for 30 or 40 minutes if you're good at what you do out there or not. I don't know. Yeah, you may be good in here answering my questions, but that doesn't mean you know what you're doing in the field. At a recent conference in Dallas called the Gathering of Eagles, the medical director for Austin Fire Rescue got up and gave a presentation about the difficulties in credentialing and certifying medics and all the different things he's tried over the last 20 years and how he couldn't find a really good way of knowing who's good and who sucks, for want of a better term. So they came up with a whole revision of their program multiple times, and his final revision was a system whereby paramedics were divided into 3 grades, P1s, 2s, and 3s. And in each of those grades, they had more responsibilities. They were allowed to do more things than in the lower grade. So a P3 was the highest. P3s usually were the battalion chiefs. They were the ones that were tasked with doing intubations in the field, with giving certain types of medications, with all the procedures, and they had to demonstrate a proficiency in this. He had a platoon system where everybody worked together on that shift, and they helped each other out. There was ongoing training on every shift. Now, these are fire EMS. They have one system. It's a one-system agency. So they do both fire and they do EMS. Now, you know from your experience that EMS makes up about 80% of your calls. And the knock that we have always taken as fire agencies with medics is that, well, you don't train 80% of the time on medicine. You only train maybe 50% of the time because you do fire training all the rest of the time. And that's true. We have to do fire training. It's part of what we do. It makes, I think, in the long run, you know, a better trained medic to look at all different aspects of your job, both medical and fire. However, as I said, that's a knock that you take when you have a fire system and an EMS system like this that are separate. So what they did in Austin was develop this system of tiered medics. The P1s were not allowed to treat patients on their own. They had to be teamed with a P2. And it took them a minimum of 6 months, and then they were reevaluated. They were reevaluated by the P2 and the P3, who was usually the battalion chief, as to their skills, if they were making appropriate decisions. On average, after graduation from their paramedic program at the local college, it took them 18 months before they could be a P2. 18 months of training. So that's a long time. But they found that doing anything less than that, they had too many issues with the care that was being rendered. Now, you know, in order to address all the issues, and this is important because when we have this all in place in a few months, the quality issues will be dealt with immediately by the senior medics. Greg and I have to work this out. It's easier at Cape because they already have this tiered system. Iona doesn't have a tiered system yet, but we're going to put something like that into place for our training purposes. In addition, you're responsible for training on the days that you're on duty and sitting around the station. So that means if you have somebody that's right out of school and a beginning medic, it's your responsibility to go over things with them, to train them. Okay, it's part of this platoon system that the medical director in Austin developed. Different idea.
So are contracts being rewritten?
It has nothing to do with your contract.
Doesn't it?
We do have a tiered paramedic system.
1, 2, and 3, it's, you know.
Who's a P3? I don't know any
Well,
P3s.
it's not labeled that way, it's a third year. It's a time and grade.
It's a time and grade thing, so.
So you mean from
And classes.
a time and grade thing from what?
You graduate school and you get credentialed by you, you're a P1.
Okay.
Paramedic 1. A year later, and you have PHTLS, you are P3.
All right, so then there is no credentialing for P2 and P3, just taking a test.
And having either your
Yeah, it's just the
Apples.
certifications and time.
Ah, I see. All right. Well, that's not what he did in Austin. The tiered system they're talking about is based upon your performance and your skills and your knowledge. It's not based upon taking a class here or doing something there. So that's a little different. And I think if we want to,
I was talking about because we have that written in our contract. That's what I was saying when we get into that.
yeah, this is that's different from what I'm talking about. We'll have to incorporate, what I like to see us be able to do into whatever it is that you currently have set up. And the reason is that you have to raise the level of your performance. And that's a general statement. Everybody, we have to raise the level of performance. I can't maintain my licensure to practice medicine without doing certain things and proving proficiency. And I mean, the basic stuff is getting 50 hours of CME a year. That's the basic stuff. And working X number of hours in clinical medicine. And you have to do that. But by the same token, to maintain board certification, I got to do even more things to maintain my certification as a physician. So it's only going to make you better. Now, I'm not saying you have to do one particular thing. This is something that the 3 medical EMS directors for the agencies are sitting down with me, and we're talking about and trying to work out what would elevate our performance as an agency. Okay, because in 3 years, I see fire EMS as one system in Lee County. The holdup right now is your medical director for EMS, and Jesse thinks it's funny, and some of your.
Talking about that for the 10 years I've been
But
here.
see, they haven't had anybody that had the ability to pull these together, and they've had more people that wanted to divide it and cut it up. And once Lemons is out in 2 years, then the door is open for somebody to be able to pull all the agencies together and to stop this bullshit with EMS thinking they own everything and control everything. I mean, because that has to stop. They're patriarchal in the way they deal with the fire agencies, and one of their main statements I already told you was that, well, they practice medicine 100% of the time. You only practice medicine 50% of the time, so you guys can't be any good. We are the people. We're the transport agencies. We know everything. So in an effort for us to document, prove, support our position that our people are as good or better, we have to have a solid training program. I have a meeting beginning of May with Edison as their medical director. I want to set up a CME program for the fall for one day where we as the fire agencies put on a CME program. And we have maybe 6 or 8 lectures. The EMS fire chiefs are giving a presentation. I give a presentation. You get CEUs for it. But I want to do it through the college so that you have some legitimacy. I mean, yeah, we can have a one-day event, but if you don't have an agency that's an educational agency certifying it, it's not going to mean anything. So in an effort to keep us moving in that direction, we're going to start doing that on a regular basis. This other thing is I want you to get involved in that ClinCon conference in the summer. The agencies, and there's only usually 32 or 33 that support it and that go to it, they send teams for the mega code scenario. A year or two ago, we had a couple of teams that went very loosely organized. They came in, wasn't last place actually, so that was good. It was, out of 32 teams, I think they were 27 and 26. So considering that they really made no prep for it, that's not bad, but you need to raise the level of performance because it opens other doors for you. I mean, you get noticed. It opens other doors in terms of funding of companies who want to promote a product or develop a product. They're going to come to the people that have some reputation in the state. You they won't come to, but the rest of them
probably
do.
not. But the ClinCon, who were like number 1, 2, and 3? Were they
Miami-Dade.
Fire?
Miami-Dade. Yeah. Many years ago, Lee was actually in the top 5 for 2 or 3 years in a row. But none of the fire agencies have been, in Lee County have even participated until recently. So I just think that it's something that, is a positive thing to do because, again, it'll bring more notoriety to you and get you noticed and bring other people to you. We're starting a tactical EMS program at Cape for CCPD for the SWAT team, and I've been talking with them and going to some of their training. I used to do that years ago with them, but I stopped. And that's a whole different ballgame. And there's programs and courses you can take to become a tactical medic. But what I'm looking for is somebody that's been a medic and has the experience and that, understands what we're doing. Because we're not practicing medicine in the traditional sense when you're dealing with a SWAT team. It's more like battlefield medicine. So all we're interested in is getting the guy from wherever he is hurt to a safe place, stabilizing him and getting him out of there. So it's a different concept, but I don't want medics who are just out of school, they won't understand some of the nuances of what needs to be done with a patient. So we're looking at that, and we're looking at developing that through the college. I've mentioned that to you before, as well as a community paramedic program. So these are some of the things that are on the horizon, and I want us to be positioned to be able to take advantage of this, because that's the future, okay? It's going to be the future of your jobs and the future in this county of a unified system. I know they've talked about it for 20 years, but you know what? I don't think they've had the right mindset of the people that do the work. It's always my turf, your turf.
Well, I think the battle is it's the hierarchy of
Yeah.
of who can hit their chest the hardest,
Yeah.
Longest.
But I think that's changing as the older people get out and the younger people come in and newer people come in. I think that's changing.
Where do you fall into that? Because you're still at the old part of that. Old part coming in, but this new is the old guy.
Well, I don't fall anywhere in it. I don't fall anywhere in it.
We can turn the cameras off if you want to punch me in the mouth.
Is the sticking point?
With us, yeah. However, part of that's because the agency tells them that, we don't need to be in existence. So, for one of saying something, more definitive, that's basically, and one of the hits that we take is the fact that, and this has been said by the commissioner as well, EMS practices medicine 100% of the time. You only do medicine 50% of the time in your training. Well, that's because we have fire too. We're going to train 90% of the time in medicine and 10% in fire. So if you look at the statistics and see how much of what you do is fire and how much of what you do in terms of your calls is medical, and you have your training along those lines, maybe that would be okay. But in my mind,
It makes your fire more dangerous, though.
yeah, it does.
Less.
It does. But you understand how they're brainwashed into looking at the training and saying, oh, well. So we have to do it better. We have to function better. We have to do it at a higher level. And we have to add these other things to it so that our training looks impeccable. I just saw a training day for EMS and the 3 topics they had, and I looked at it and thought, you got to be kidding me. Well, you say that laughably, but the truth is, yeah, there was something in there about documentation for that. What was the other? The X-collar stuff, all the change they made unilaterally with the X-collar. And there was one other topic. None of it really can justify them saying that they train 100% in medicine, because they don't. It was only a 3-hour program. And they had 3 different people lecturing, and those are the topics. So,
They don't do it that often.
no, they don't. They don't even do it once a quarter. But I also know that from somebody at another agency that's not doesn't have the same medical director as your agency or the counties, said that their medical director only lectures a couple times a year, maybe once a quarter, if that. He does not participate in their training program. He brings stuff in and whatnot, but he doesn't really have any kind of lecture series. So I just think it's important for us to have a certain standard that we expect ourselves to uphold and to promote as a standard that should be done for all the agencies. And I can't do that with all the agencies because I don't work for anybody else. I work for 3 agencies and that's it. But if we set a standard and set the bar, there could be something that improves the overall fire EMS system in this county. And that's what I'd like to be able to do. Okay, so we're making a change a little bit in keeping with what I wanted to do. And starting in June, we will have a common series that we're going to deal with. And in other words, each month the topic's going to be sent out ahead of time. So you should have, let's see, this is May, this is April. Starting May, you will have the topics for the next 6 months sent to you. And you can pull them up on the web, you can pull them up in your email, and those topics are going to deal with things that we're going to be seeing at that particular time of the year. So for instance, you know, you're going to see heat stroke as one of the topics. You're going to see envenomations. You're going to see environmental emergencies, you know, marine emergencies, that type of stuff during the summer, because that's what you're going to be dealing with in the street. So we want to try to keep it topical and current with what it is that we expect you would be seeing. So you will have that information 6 months in advance. So you'll know in November we're going to be talking about cardiac emergencies. I'm just giving you an example. And you'll know, okay, well that series on that month is going to be this. The lectures or the in-service day is going to be divided up into my lecture, participation from the rank and file in their presentations, quality assurance issues that we will cover, and some skill sets which we haven't decided if the skills are going to be done just by one of the chiefs. So in other words, either Greg or Ryan Lamb or Seth Comer or his associate, I don't know who that's going to be yet, will be demonstrating skills and going over skills, and we may do it, you know, on the web. We may do it in person. I don't know. This is, you know, this is in a state of flux and in a state of formation because this is something new that nobody's done. I mean, the days of somebody walking in here giving you a 3-hour lecture and leaving are over. I'm certainly not going to do it. And if you think about it, how much have you learned with previous medical directors coming in here and giving you a 3-hour lecture and walking out the door? How much of it do you even recall?
Are you even here right now? Huh?
No. It's just a figment of your imagination.
Wow.
And you have a heck of an imagination. So, you know, we want to make this more interactive. One of the criticisms I've had from one of the agencies was that I didn't put this in a PowerPoint and put it on the board and present it to you with all the facts in it. And I said, point blank, and Chief DeWitt was there, I said, look, part of this is them getting the information in their book. Because when they're on the scene and somebody's telling them stuff, they have to know what they're hearing. They have to know what's being told to them. They have to understand it. They don't get it printed on a piece of paper. Oh, this is Mrs. Jones, and she's been having chest pain for 3 weeks. That's not the way it works. So it's how you get what you hear and put it on a piece of paper if it's accurate or not. Not my job to spoon feed you. You're all big boys. You can take the information and write it down. So it's important. It's part of the learning process. I am not going to put it on a PowerPoint. I'm not going to type it up. Now, if one of you wants to do that or your chief wants to do that and hand it out to you, that's your business. But I think it takes away from the purpose of what we're doing. When you come before me, do I hand you a piece of paper that says, this is your case? No, because that's not what it is in the field. You know, you need to be able to do the same thing in front of me that you do in the field. And Jesse, that means your pants have to stay on.
Oh. All right.
So it has to be the same thing. You have to, I want you to have the same tension. It's important because the more you do that, the more relaxed you become. My daughter, this as an aside, it was funny because I heard this. My wife told me this. My daughter's going into her 4th year of osteopathic school, and she's doing an ER rotation in a teaching hospital. And she called my wife and said, oh my God, you won't believe what I just saw. So my wife figured, oh, it must have been something really interesting. And she said, oh, what was it? She said, I saw the worst code being run in my life. And she said, well, why do you say that? She said, well, you know, when I was with Dad and he ran codes, everybody was calm, they did their job, he told them what to do, you know, and he was calm, he did all his procedures, there wasn't blood everywhere and people running around like madmen. She said, I was in this ER and this resident was running the code and their blood was everywhere, squirting all over the place, he was sticking holes in this woman, he couldn't intubate her, the nurses were screaming, he was screaming at them. She said, I have an appreciation for why you need to be calm in that situation and why it takes a lot of experience of doing this over and over and over again. And yeah, it gets boring and it sometimes drives you crazy, but it's important. That's how you get better at what you do. And that's how you set the tone in the street. But to do that, you need experience. One of the issues that the medical director at Austin had was, what does he do with those guys that are at Station East Jabip and see 3 patients a day at best? How do they get the experience? How do you get guys that have been at the same station, and we had this problem at Cape, for 10 years and have treated a total of 40 people in 10 years? How much experience do you think they're going to have? How skilled are they going to be? And when they make a mistake and you try to talk to them about it, they take it as a personal affront. They don't learn from it. We were fortunate in that individual resigned their paramedic position. It was a good thing. But the point is that where do you get this training? Where do you get this constant retraining of your skills? Because you have to have them. How many of you have intubated more than 100 people here? 50. 25. So, and how many years have you been paramedics? And you've only intubated 25 or less patients in all that time?
Most of that was in school.
Remember what I told you. To be skilled in intubation, how many do you have to do? You have to do 50 to get the skill. You have to do 30 a year to maintain the skill.
Well, you can't go out in the field and have people, you know,
I understand.
on you and be sick on you. I mean, it's just not, you know.
I understand. So what they've done is, and Seattle has a better program for this, is they've taken the training portion and they've implemented that into their routine medic program, meaning that you're working for fire EMS in Austin and you have X number of days a year that are your training days where you go to the hospital and you do intubations, you do lines, and they have this set aside for you. Because of the volume of programs in Lee County, we don't have access to the hospitals to send you in there for a day to do procedures. I mean, that's ideal.
But aren't they using LMAs in ORs now and stuff now?
Some of them, yeah.
So, I mean,
My daughter had general surgery and was intubated.
how old was he in? Probably a little old school and.
No, he was a young anesthesiologist. It was at Gulf Coast, too. She was tubed by a medic because they asked her.
The length of the surgery up at Fawcett, if it was 3 hours or less, there's an LMA. If it's 3
She had an umbilical hernia repair. So it wasn't that long, but she was intubated. She didn't get an LMA. And you know, the trend in the field is now coming back to intubation again. You know, the last statement put out by local protocol committee was that, well, maybe we should consider passive oxygenation, just putting a nasal cannula over their nose or mouth while we're doing chest compressions and CPR. Because there was some study that was done which suggested that passive oxygenation works.
Not 10 minutes after the code. Yeah, there's a study you get there.
Yeah. Did I give you the presentations on the 5 best articles from 2013 and the 5 worst articles from 2013 in terms of data that they're spewing out that's false? Yeah. We have to go on the website to look at it. But what I would recommend is, if you have nothing else to do when you're on duty, go to agatheringofeagles.com, www.agatheringofeagles.com. Okay, that has in there, every year they put their syllabus in there and all the lectures. Now, the lectures are not videoed, but you have all the slides, and you can look at these things. And as an example, you can look at the medical director from Austin that developed this program, and you can also look at these 5 articles. Every year they do that, the 5 best and the 5 worst. And they also have a big thing, and you've heard this from me 3 years ago, 4 years ago, a big thing was ketamine. They are pushing ketamine like mad. They love it. One of the medical directors did a study on ketamine and complications, side effects, and he found, when he developed the protocol for it and implemented it, the hospitals were like, oh my God, ketamine, just like they do here in Lee County. So that's universal. Oh my God, you're going to be giving, everybody's going to be coding left and right. Yeah, okay. So he developed a protocol, put it into play, and then after 1 year, he had like 7 patients that required intubation, all from the same hospital. They were all brought to the same hospital that did it. None of the other hospitals intubated anybody. But when they brought patients to this particular hospital with this particular physician, he tubed every one of them. He tubed 7 people, saying they were in respiratory distress and had to be intubated.
Because you're on ketamine.
Because they got ketamine. He's the only one out of the 150 doses that they gave. It was only that doctor at that hospital that did it. Nobody else in that whole city did it. And I forget what city, if it was Kansas City, I'm not sure. I don't remember the city. But it was interesting because, again, it goes with the stigma that ketamine's such a big problem. I use it in the ER. I use it in kids all the time. It's not a big problem. You have a set protocol of how much to give, what you're looking at, how long it's going to last. It's a great drug to use. But you still deal with people that have these preconceived notions that it's a bad drug. Okay? Unfortunately, I don't know if we'll ever get it in this county. So I would recommend you go to that website. There's a lot of good stuff that these guys are state-of-the-art pre-hospital care. Okay? This is where all the information that's factual comes from. It comes from these 22 medical directors. And these are big agencies. This isn't GEMS. They don't work for GEMS. These are almost all teaching institutions or big city agencies that are almost always fire EMS. I don't think there might be 1 or 2 that are just EMS, but most of them are fire EMS. It's always held in Dallas. Good thing to go to. I went not this past year, the year before. We had a great time with the lectures, and then of course at night with the food and the other things. So it's definitely worthwhile to go to if you can. Usually Cape goes, Ryan and Tony Demos, I think, are the 2 that usually represent the Cape, sometimes the 3rd one. Iona hasn't been there, and I don't think you guys were there, so. But it definitely is worthwhile. It's something that we should look to do. At least one representative from here should be going. Doesn't have to be Greg necessarily, but should be somebody, just to bring that information back.
What's the name of it again?
Gatheringofeagles.com.
I've got the website, I'll send it out. It was on last month's.
Yeah, I thought it was.
Yeah, I pull from that occasionally to look at things in there that, are more cutting edge, state of the art. It's good to see what's coming down the road. Okay, so look, today is going to be the last day we do it this way. So we have a presentation, I guess, on capnography.
Yes,
Calvin, you can do your thing. Anybody else have a presentation today? You do, but you don't? No, I can't see if I sit here. I think this is something important that you guys do. I think this is important for you to be able to get up here and talk about this stuff, because you have to do it in the field anyway, not necessarily talk about a medical issue, but you have to be able to be a leader. And in addition, I need you to be able to teach each other. Because one day I'll be dead and gone.
I decided to do my slide on capnography. It's a pretty important tool, and it should be used as much as possible. It's considered the golden standard. Capnography is the vital sign of ventilation. It should be included in your normal vital signs if and when you can do it. By tracking the carbon dioxide in a patient's exhaled breath, capnography enables paramedics to objectively evaluate a patient